interventions, and I'm excited to introduce Elliott Main, our keynote speaker in this session. So he is a clinical professor in OBGYN and a maternal-fetal medicine specialist. He's the director of the California Maternal Quality Care Collaborative, and he is especially well known for all of the state and national quality improvement projects and efforts that he has led and instigated and implemented. And he's also been part of the California Pregnancy-Associated Mortality Review, the chair of that since it started in 2006. So Elliott.
Thank you very much, Susan. And as Dr. Bateman was talking about big data, and I'm going to be talking about big QI. You know, we all do QI at the local hospital level, but this is now, how do you make change at scale? California is a big state, bigger than most European countries, actually. 40 million people live in California. We used to have 500,000 births. Now it's down to about 420,000 births. But even now, it represents 1 out of every 8 births in the United States occur here in California. And the number of California hospitals delivering maternity services has slipped some as smaller units have closed, but we still have 225 hospitals that serve maternity units. And we have great diversity, both in terms of races, ethnicities, urban centers, large rural areas, farmlands, deserts, mountains. So our challenge is as the California Maternal Quality Care Collaborative is how to improve care throughout the state. We are a multi-stakeholder collaborative founded in 2006, now celebrating 16 years in business. Launched initially with the funding from the California Department of Public Health to address the rising scene in maternal mortality. And we've taken and pioneered a very discrete course of taking the maternal mortality reviews, turning them into quality improvement toolkits, and then change collaboratives, partnering with everyone we can think of along the way, driven by a rapid cycle maternal data center. And I'm going to talk about these interventions as we go along here. So this is maternal mortality in the US in red and California in blue, showing the rise in the first decade of this century from 7 to 9 to 16, so almost doubling in California. And this is when the state of California said, okay, we need to really investigate what's going on. As a background, maternal mortality in the country is about 22 per 100,000, but it's divided into different categories, underlying causes, of course. Cardiac disease is the most common one. 25 to 30% of all the deaths in the United States and in California are due to cardiovascular disease, which is about 4 to 6 per 100,000. So again, the deaths are not big numbers, but they are in contrast to where we were, in contrast to other developed high-resource countries. The 4 other group causes, and many studies link embolism and AFE together, which aren't really the same, of course, but an embolism, infection, hemorrhage, and preeclampsia are all, give or take, year to year, up and down, around the same number of about 10 to 15% of deaths. Again, these are small numbers. So as Susan was talking about in the last talk, we really have focused on severe maternal morbidity, which is almost 100 times more common. You know, now it's up to 1.8% of all births. But note here in yellow that the changes in frequency. So now hemorrhage and preeclampsia and hypertensive disorders dominate the underlying causes of severe maternal morbidity. They have been, for maternal mortality, the most preventable causes. Upwards of 80% of deaths from hemorrhage and preeclampsia are preventable. And on our maternal mortality reviews, we could find that they had very high rates. 90% of cases of these had quality improvement opportunities. So that led then led to the development of quality improvement toolkits that harness these lessons learned from maternal deaths and a review of current literature combined with practical approaches for how to make change on labor and delivery. So these were various guides for implementation. They've been very popular, downloaded each about 14,000 times. So that included throughout California, but also heavily used throughout the nation. The next step was quality improvement collaboratives, which we did a series of with different funders and different, remember we have 225 hospitals in California. We worked with the small cohorts to get it down, and then ever bigger cohorts up to 130 hospitals, not counting some of the big systems that we're using our toolkits to do it internally, like Kaiser's and Sutter's. So what happens in a CMQCC collaborative? We require that each hospital develop a project team that needs nurses, providers, administrators, as well as community members. We get everyone together, at least we did before the time of COVID, to level set with background education, introductions to toolkit, and getting to know each other, because actually sharing among groups is an important part of a collaborative. Everyone has good ideas. Everyone has things that they learn and discover that can be used by others. It's not something that we at CMQCC have all the answers for. So then the collaborative is divided into groups of 6 to 8 hospitals with a physician and nurse coach or mentor that works with these teams with monthly calls for either 12, and we've extended to 18 months because that's what it takes to make some of the impacts that we've seen. So these address barriers and share among each other the learning opportunities for strategies. Of course, you have to have a set of measures to gauge progress, and these include both structure, process, and outcome measures. And this is where our maternal data center plays a huge role for making that easy to do. And we'll cover that later. So what's happened after we started these interventions around 2010? We've seen a big difference now in California's outcomes versus the nation as a whole, which has continued to rise and remains even in the last 3 years in the low 20s, 22, 23 is the latest numbers. The latest numbers from California Department of Public Health shows remaining around 7 to 8 per 100,000, which is again, now we're in the range of France and Great Britain and some of the other countries in Western Europe that we've aspired for. So let's look at some of the recent years of some of the underlying causes here. So these are the major causes: cardiovascular disease, hemorrhage, sepsis, hypertensive diseases of pregnancy, and here we're able to divide into the thrombotic pulmonary emboli and AFE. What I'd like to draw your attention to is the change just in the last couple of years for hypertensive diseases. They were stable, 25 deaths over each 3-year period in California. Remember, we have a very large number of births in California. So the rate here was in that 1 to 2 per 100,000 that we saw in that very first slide. But in the most recent time period over here, you see a fall by 75% to only about 1 or 2 deaths per year, averaged over the last 3 years. We have worked really hard spreading the word about prevention of stroke and preeclampsia by treating the blood pressure. Maury Drusen in our department was the lead author of that, and he's spoken extensively around the state, but that's pretty exciting. When you look at hemorrhage deaths, we don't see that fall in deaths. We've just finished a big review of 60 hemorrhage deaths over the last couple of years, 6 or 7 years. And what we see actually is a 50% fall in deaths from atony, which is what our toolkit was really focused on, how to respond to a hemorrhage. But at the same time, we had a 50% increase in the deaths from accretas. So that's our challenge, is how to prevent accretas and how to treat them better. Some of these actually were deaths in tertiary centers from per accretas. Some of these were unrecognized accretas occurring in smaller centers by misdiagnosis from ultrasound. So that leads us to the next challenge, was how can, accretas are related to having prior C-sections. So how can we prevent that first C-section? So that's our next big project that we did in California, which is try to prevent the first C-section among nulliparous, term, singleton, and vertex women. And what we started off seeing was just that there's huge variation in care. This is the C-section rates for every hospital in California, 248 in this time period. And you can see that they ranged from the low teens, 12, 14, 15%, up to one hospital that was 70%. Those are outliers, but you can see that there were a lot below 20 and a lot, and above 35%. So why should it make a difference which door you walk into as a pregnant woman in terms of your C-section rate? So we launched a collaborative to work on this because it's about big time change now. So we invited every hospital that had a higher rate than the national Healthy Person 2020 goal, 23.9. And the red lines are the ones who joined. So 56 enlisted in the first two cohorts. We actually got it up to 99 by the time we were done. And again, we had a set of collaboratives and a toolkit that really, and we worked extensively about addressing labor culture or labor support, as well as giving feedback to physicians about their own rates. And we actually had a similar slide to what I showed for maternal mortality. This is US in red, California in blue, and we had been stuck at the same rate as the US as a whole, 26% for first births. The overall C-section rate was about 32% in California, but for first births, it was 26. It's higher overall because of repeat C-sections, of course. So we were able to bring this down actually below the healthy person target of 23.9. Actually, there are 5, 6 other states that are well below that statewide rates. So we're now in much better company. And what we were able to do is a balancing measure here, a safety measure, which is severe unexpected newborn complications. So these are babies that are otherwise healthy, term, singleton, no birth defects, no pre-existing conditions. Did they have a major complication, a birth injury, a perinatal compromise or asphyxia, sepsis, those sorts of major issues? And we were hoping that it would stay flat, but it actually improved significantly with the fall in C-section rates. So how do you make change at scale at this level? And this was engaging absolutely everyone we could think of. At the hospital QI level, we did a data-driven QI initiative with intensive feedback of provider level numbers, as well as hospital numbers to compare with. We got ACOG involved, ACNM involved, the Nurse Midwife Association, the Nursing Association, A1. They were all leaders in this project. We had a pretty comprehensive toolkit that gave people lots of ideas to go along with the monthly sessions. And we actually appealed directly to women with some very nice apps in short videos. But you can't make change unless people are engaged. And that's where the statewide actions really came into play. If you're going to change something, you just don't want to take the people who raise their hands first. You have to get people to want to raise their hands. And so we engaged health plans, our Medicaid agency, to give incentives for participation or incentives to have a lower C-section rate. Payers and purchasers talk to the hospitals. It makes a big difference. In Orange County, if the Walt Disney Corporation goes to hospitals and says, we think the C-section rate's too high, or if Google does that in Silicon Valley. And so employers actually have a big pull here. The public health department has a very interesting role to speak about in a moment. And then we did a lot of public reporting and transparency. But the spectrum of stakeholders to make change at scale is pretty daunting. And this is where I spend a lot of my time, working with a whole variety of state agencies, professional organizations, public organizations, and what we call membership organizations, which are like the Hospital Association, Pacific Business Group on Health, and some of the big payer organizations. All these folks have roles to play when you're trying to make change at scale. Not counting, not even mentioning the medical leadership for the Kaisers, the Sutters, all the big systems are involved in this project. We actually went national on this as well. We got the Joint Commission decided what we did in California was so good that they've adopted our hemorrhage and hypertension bundle elements and turned them into a set of perinatal quality measures. There are now, we were one of the very first state perinatal quality collaborators, 2006. We've got now grants from HRSA to ACOG, nationally developed AIM, which is an initiative now that has 48 states with perinatal quality collaboratives. The CDC is now helping fund 23. We just got a grant from the CDC to do the follow-up project on equity. And CMS is now engaged in this realm as well, for part of the inpatient quality report for every hospital in the country. It's about adoption of patient safety bundles and participation in state PQCs. So that's pretty exciting. And then our state and a number of states have 1115 waivers, which is code word for disproportionate share monies, now have to be for quality initiatives. And a number of those, including in California, have given incentives for quality measure in maternity care. So this is kind of fun. This is the carrots involved. So the Secretary of Health and Human Services for the state of California for the last 5 years has now given awards to hospitals to meet the national target. And we learned very early on how much hospital CEOs love to get awards. Just a piece of paper, no money attached, but they want to have awards to show how well they do. So it's a public relations thing. On the right-hand side, we also did transparencies and shared C-section rates, breastfeeding rates, episiotomy rates, et cetera, for every hospital in the state of California on websites. And then it was picked up by Yelp. And this is really interesting. Every hospital in the state, if you go to their Yelp landing page, will give you comments on the left about how great the nurses are, and maybe how not so good the food was. But on the right is our maternity care measures on the landing page. And they're coded, and you can click on those and then actually go to the actual rates in comparison. This is driven by the Maternal Data Center, which is a rapid cycle way of doing the linked data sets that Dr. Carmichael was talking about. So we do this monthly with monthly feeds of birth certificates and monthly feeds from hospitals for their discharge diagnosis files, both for mother and baby. And then that's not much else that we need to do detailed quality improvement projects. And that allows us then to stratify all these reports by race and ethnicity, which has been a really important step forward as we look for equity work. So it supports QI projects, and it bypasses the biggest cost and barriers for QI, which is data collection. And we're now working to figure out how to share the data beyond the hospitals to local community organizations, community level data. The data center is interfaces that are really friendly and allow people to visualize their data automatically, both in terms of run charts, benchmarking against others. We even gotten some fancy control charts in there, and then can break down complicated measures like severe maternal morbidity into their components to allow you to see where to do your quality improvement work. So our current challenges are racial inequities in postpartum care. I'm going to focus here on maternal mortality initially. You can see that Black mothers, Black birthing persons in California have 4 to 6 times higher rates. It's dropped in the last 3-year period to 3 to 4 times. But this is unacceptable, and no one has really figured out the right approach to deal with this. We've been working with a number of community groups and are about to launch a data-driven quality improvement project for addressing equity issues, particularly in combination with a quality improvement project. So this involves actual activities and actions that are beyond implicit bias training, such as a commitment to safe and equitable birth that would be in every birthing unit, signed off by every nurse, every birthing room, signed off by every nurse and physicians, promising how we're going to treat you with dignity, respect, we're going to ask permission for every exam, et cetera, et cetera. We're launching a culture of equity survey among 4 pilot hospitals right now, which I think is going to be very informative. deal also with resources to address microaggressions, and find out ways to hear from patients, getting that patient feedback. The last thing I want to talk about is postpartum. And we talked about cardiovascular disease right at the beginning. Cardiovascular disease happens in the deaths from cardiovascular disease happens in the postpartum period. 50% of the deaths are after 7 days. 1/3 of all maternal deaths are in the postpartum period. It's largely cardiovascular disease, sepsis, and a little bit of hypertensive disease, particularly in the first 2 weeks. So this is the big challenge going forward, and we really need to redo how we do postpartum care, to do the handoffs right, to do the connections, and to keep mothers in care. So I'm going to end with a thank you to an incredibly dedicated and multi-talented team we have. This is our celebration for the first time getting back together after 2 years of COVID, with our new facility at 1701 Page Mill. So thank you, and I look forward to working with everyone.
Hey. Thank you so much, Elliott.
Yeah, let me stop sharing.
Great, thanks. So our next talk is going to be, we're moving into a speed talk with Deirdre. And just to briefly introduce her, she is a professor in OBGYN and maternal-fetal medicine. She is medical director of labor and delivery, and she directs, importantly, the Stanford Placenta Accreta program. Much of her work is aimed at preventable maternal morbidity, and I've really enjoyed working with you and getting to know you as we've developed the population-based SMM work we were talking about earlier. So,
and likewise, thank you. I hope you can all see this. So Elliott, thank you. Your talk is actually kind of a nice setup for what I'm going to describe, work that you've been involved with and so many others here. Dr. Iro Igbinosa, Stephanie Leonard, Susan Perez, the Black Wellness and Prosperity Center, Shante Davies-Balch, and Kata Nemeth in particular, and we'll hear from Kata later. But this is essentially a project that is aimed at combining both the clinical standards with community and implementation science approaches to create what Elliott has described as essentially like a toolkit in order to reduce, in this case, iron deficiency anemia at birth and to improve birth equity. Now, why do we pick this? Well, so many people arrive in pregnancy iron deficient. So 1/3, it's estimated, of those who start pregnancy are iron deficient, usually through menstruation, but diet plays a role. And this is in the United States, and the numbers may be different worldwide. And then half are actually iron deficient in the first trimester. And this leads, it's a precursor event to iron deficiency anemia, which is just low blood count. And it's estimated that 10 to 40% of people in pregnancy at their birth admissions, they show up to labor and delivery at their birth admission, they have iron deficiency anemia. That's too high and it's preventable. So why does this matter? Well, iron, as many of you know, really is a key substrate to build hemoglobin, which is basically blood. Blood delivers oxygen and nutrients to fetus. It's critical for growth and development, fetal growth and development. It's also critical in fetal development. It's a substrate for the fetal hippocampus and neurotransmitters. Hippocampal development is really critical for lots of neurodevelopmental kind of good things to happen. And we know that those infants and children of mothers who were profoundly iron deficient during pregnancy or even moderately have had demonstrated issues reported around processing, memory, different kind of neurodevelopmental tests that are really important, and these have been replicated. We know that neonatal iron deficiency is also difficult to reverse, and because neonates absorb iron really very poorly. There are lots of maternal reasons during pregnancy why it matters as well. It can lead to fatigue, shortness of breath, dizziness, depression, days missed from work, lots of other things. But the real critical time for moms is at delivery. We know that uterine blood flow increases by about 5-fold in pregnancy. There's a lot of blood that's going to that uterus in order to grow the uterus, to grow a baby. And you can imagine when there's something goes wrong at delivery and there's a hemorrhage, the uterus doesn't clamp down the way it should, something happens. Someone can bleed very, very quickly. And there's actually a 6-fold increase in major maternal morbidities and SMM related to iron deficiency anemia. Number one is going to be blood transfusion, but also Iron deficiency anemia itself can create other problems such as hemorrhage, infectious morbidity, preeclampsia, as well as preterm birth. So one way we think about this, the gas tank is like you wouldn't drive to the mountains with a gas, like a tank half full. So same, like, why would you come to labor and delivery also with kind of not fully optimized? There's also a really important racial ethnic disparity here in iron deficiency anemia at delivery, 2 to 4 times higher rates of anemia among Black pregnant people versus white, and 1.5 to 2-fold higher greater rates among Hispanic and Latinx women. Anemia can also exacerbate other disparities. We know that Black pregnant people experience 2-fold more frequent SMM, and this is independent of sociodemographic factors or comorbidities. Anemia itself, as I mentioned, can increase the number of SMM events, and SMM increases the risk for death. So back to what Elliott was also presenting, that this is an opportunity to really move the needle across a lot of areas. We know that Black pregnant people in particular have a much higher rate of mortality. And so it's been estimated that about half of maternal morbidity and mortality is preventable. We know it's not all, but about half is. So it really begs the question, why after 7.5 months of prenatal care is iron deficiency anemia? Why is there so much? We know that that is also preventable. And unfortunately, we're going in the wrong direction. This is data that Dr. Igbinosa led, looking at using the California state data from 2011 to 2019. And the upper line shows antepartum anemia among Black pregnant patients. And the blue line is among white pregnant patients. We know that it's increasing among all groups. And it's also that disparity is diverging. So what's very clear is that our current approaches are not working. And in particular, there haven't been any studies that consider the perspectives of Black or Hispanic Latinx gravidas on iron deficiency anemia in pregnancy. So we're addressing this via a 2-pronged approach. First, working with communities to really understand what is their awareness of the problem and treatment. We're working to design patient-specific and clinic and community-based education and messages about anemia in pregnancy. Katja Nemeth is going to talk a little bit more about that later. Among providers, we're working with providers in California, Oregon, and Washington to standardize care and to create essentially a toolkit and just a standard approach to how to work this up, but a lot of education too. Medication interferences. There are a lot of things that we do as providers that actually that don't help with anemia, even when we're prescribing iron. Dietary education too. I know I'm low on time, so I'm going to kind of skip through that. Really briefly, we had a Spectrum grant and utilized that to do qualitative work with Black Wellness and Prosperity. And Katja will talk a little bit more about that later, but really learn some important insights around anemia, but prenatal care in general and where some of the gaps are. Through our clinical leadership group, we've been meeting monthly since 2021, and we've really identified a lot of what we know. There's very heterogeneous approaches to how we work up and treat this, and there's a lot of gaps in care that we will be addressing through this toolkit. Ultimately, we're going to meld the community group as well as the clinical collaborative group recommendations and ultimately come up with a better approach. So thank you.
Great. Thank you, Deirdre. That was great. Okay. Now stop sharing. Great. And now I get to introduce Haley Miller. Welcome, Haley. So I'll introduce you and you can go ahead and share your screen. Haley is a second-year maternal-fetal medicine fellow. She is committed to bridging the gap between maternal-fetal medicine and family planning as a means to optimize preconception and postpartum care in order to improve severe maternal morbidities.
So thank you so much for the introduction, Gianni. I actually do need you to share my slides because I just got my computer fixed and it's not allowing me to share my slides. Let's see. Are you able to?
Yes, just give me 1 minute.
Okay, thank you. Actually, here, I can do it now. I fixed it. Okay. Let me. All right. Are you seeing my slides, everybody? Okay, yes. Great. So thank you for the introduction. I am Haley Miller. I am one of the second-year maternal-fetal medicine fellows, and I will be discussing the clinical trial that myself, Dr. Lyell, Dr. El-Sayed, and Dr. Kate Shaw and Dr. Blumenthal are working on, and Dr. Leonard. I will be talking about mifepristone as an adjunct to transcervical balloon for labor induction, a randomized clinical trial. As a background, induction of labor is a topic that has captured the interest of healthcare providers, patients, researchers, and policymakers. I want to start by defining induction of labor. It is the stimulation of labor for the purpose of accomplishing a vaginal birth. Induction of labor is warranted when the benefits of expediting delivery outweigh the risks of continuing the pregnancy, for example, in the setting of preeclampsia at term. But more recently, the discussion of elective induction of labor has gained attention and popularity nationwide. So for those of you who are unfamiliar with the process of induction of labor, the birthing person is admitted to labor and delivery. The OB team establishes the medication or method to prepare the cervix for induction of labor. The average duration of labor is between 1 and 3 days. And in most cases, a vaginal delivery follows induction of labor. Currently, the landscape of induction of labor includes 1 in 4 gravid people undergoing labor induction each year. So the ACOG practice bulletin, although old in 2009, cites that about 25% of gravid people undergo labor induction. However, in 2018, a study was released that we're most familiar with, the ARRIVE trial. And the findings favored elective induction over expectant management at term, and this led to a steep increase of labor induction. What that means is institutionally, we have seen an increase of induction of labor. At LPCH, approximately 40% of spontaneous vaginal deliveries follow induction of labor. And this is a mean duration of about 20 hours or longer when the cervical preparation is required. This mean duration has been consistent when comparing institutional data from 2005 to 2020. It has not wavered with time. With increasing labor induction incidence and long durations of labor, labor and delivery beds are occupied longer, hospital costs are increasing, and medically indicated labor inductions are delayed. So robust evidence has helped to guide improving the induction process. Cervical preparation is an integral part of labor induction. Induction of labor begins with cervical preparations, including medication and mechanical options. Several methods have been studied in attempts to achieve the fastest, safest, and most efficacious ways to end with a spontaneous vaginal delivery. However, labor induction times have not substantially changed over time despite these efforts. So there is a need for new methods and models to decrease the hospital induction times. So mifepristone is an FDA-approved medication for first trimester medication abortion and is used off-label for cervical preparation for second trimester abortion and stillbirth induction. Mifepristone has been shown to reduce the time to delivery by 40 to 50% and decreases overall morbidity in the second trimester induction of labor. It is a progesterone antagonist. Progesterone inhibits contractility of the uterus. So mifepristone has a potential of inducing labor through its actions and antagonizing the progesterone that is stable throughout pregnancy, thus increasing uterine contractility and by increasing the sensitivity of the uterus to the actions of prostaglandins. Mifepristone internationally has been studied for induction of labor, and it's been shown to increase the rate of vaginal delivery. People who have received mifepristone compared to placebo were less likely to undergo cesarean section, were less likely to need augmentation with Pitocin, and there was no differences in NICU admission or APGAR scores among the neonates that were in the studies. So this brings us to the MILI trial. which is launched here at Stanford. So this is a pilot 2-arm randomized control trial of nulliparous people induced with a transcervical cook balloon, comparing perinatal outcomes among people who received mifepristone versus misoprostol. So as I said, it is a parallel 2-arm non-blinded superiority randomized control trial with a total of 30 patients. 15 patients will be receiving cook balloon and mifepristone as a cervical preparation agent. And this will be compared to patients who are receiving a cook balloon plus misoprostol. The aims of this pilot study are to generate preliminary data on perinatal outcomes, examine recruitment feasibility and willingness of participants to be randomized to guide recruitment periods for future studies. There are a myriad of outcomes that we're looking at, including number of uterine contractions with and without fetal heart deceleration, and importantly, time to delivery, vaginal delivery rate, and cesarean birth. We're also looking at neonatal outcomes, which obviously are extensive here, but in summary, a comparison of neonatal cord gases, APGAR scores, and a composite of serious neonatal morbidity. We're including, in summary, nulliparous patients aged 18 to 45 that are overall uncomplicated and are eligible for a vaginal birth. And just to summarize our study recruitment updates, 300 people have been screened, 29 have been eligible, 13 have been enrolled, and 11 people have declined. However, among those 11 people, 4 have consented for a prospective chart review. And I just want to acknowledge MCHRI for funding this study and my collaborators that include Kate Shaw, Yasser El-Sayed, Deirdre Lyell, Paul Blumenthal, and Stephanie Leonard and KJ Jennings.
All right. Thank you, Haley.
Thank you.
Well, that has been a really amazing set of talks. I love the breadth that we've covered in the terms of intervention from QI to an RCT. So now we can have a little bit of discussion. We do want to retain our break time. We were originally going to break at 3:30, but we have time for a couple of questions. Let's see what we have in the chat. I think, Pervez, you had a question that's kind of similar to, I was thinking about that too. I think this is mainly to Elliott and Deirdre. How can we go about replicating these successes in other parts of the US that urgently need to address their ever-rising maternal mortality rates? Are these results reproducible? And I was, wondering about what's the, it's exciting that all 50 states have a PQC now, but what's the capacity and what are some of the limiting?
So the key is that they're at very different stages of development, right? As I noted, we started in 2006. So we've been ahead of the game. In the first couple of years, we were doing maternal mortality reviews and putting together stuff like toolkits before we actually made any change. So the changes came really almost 10 years into it, or eight years into it. And so we're seeing some very mature collaboratives, like in Illinois, that has some pretty impressive outcomes. Iowa's doing some really good job with their C-section rate. I've been out there a couple of times. I've actually, I think, been to 42 states now, either in person or in Zoom in the last couple of years. But this is catching on. Massachusetts is doing some really exciting stuff with equity that we're collaborating with. But it's a fair amount of work to get everyone together. I would say, though, that states in the Deep South have been slow to the game, with the exception of Louisiana. We have some really nice colleagues there that are putting together all the collaborations that you need. You can't do this as a single person. You can't do this even as a single organization. It's really about collaboration. And that's not necessarily easy to make happen. And that can take some time and some push. Texas is an interesting example. They have 2 perinatal quality collaborators, one by the State Health Department, one by University of Texas. And they're sort of competing and not, and it's who gets the data. It's really a little unclear. But Texas is Texas, so you have to sort of say they're going to do things differently. But they have almost as many hospitals as we have in California because they have a huge amount of rural open spaces in Texas. So it's a challenge, but I think, finally we're getting funding for these perinatal quality collaboratives. Most of them existed on really, $50,000, that kind of stuff, but that's not going to cut it to make the kind of change you need. But now federal agencies are starting to fund them at a much higher rate. And people are getting funding from internally in their states. Most of our funds actually comes from our hospitals, half of our budget, because we give a lot back to the hospitals.
And Elliott, to add one thing that I've heard you say is that a lot of states across the country also, like these California projects roll across country, that a lot of states follow suit. And so there's potential for whatever we do to move the needle here, maybe having some wins across the country too.
It brings very positive attention. And
so Brandon Carvalho and I were at a WHO meeting in Geneva, and sitting next to us was a obstetrician from Cali, Colombia, who had used the CMQCC toolkits for 50 hospitals in her region in Colombia. And they could claim they had a 50% reduction in maternal mortality. So that was really exciting and fun. So yeah, we do have impact.
But to that point also, Elliott, through your introduction and my work, I've been working with people in Illinois and Louisiana, and it's just been fascinating to me how they just don't even have access to their state data, and at all, much less in a feed that's quick. So very limited. It's just tough.
Really important breakthrough is, our mantra is free the data. Making state administrative data useful for quality improvement has been one of our strengths here in California.
So I wanted to make sure, so there's another question in the chat. We can do that briefly. And then I wanted to make sure, I had a question for Haley. So for Elliott, could you comment about the recent publication about, coming out of Yale, looking at health equity checklist to improve identification of equity-related adverse events?
So this is a checklist that they use when they review cases of, like, say, severe maternal morbidity. And it's similar to what we use in our maternal mortality reviews, which it's a tricky issue as to how you define whether discrimination or equity was a contributor in a particular case, because it's not often described well in the medical record, because that's the people who wrote it. To really get the story, you need to do interviews and hear from patients or their families. So it's a good start. It was piloted at one hospital in New Haven, at a university hospital. We are working on how to do maternal morbidity reviews at the hospital level. And I think something like this will be useful.
Great. So Haley, I just wanted to ask you, really appreciated your talk as well, and all the issues it raises. Just wondering what you're thinking, as we've talked about the other talks were about these large scale, bringing to scale, what your thoughts are about bringing the work you're doing to kind of the next steps and some kind of scale.
Yes. So kind of following previous national studies, we hope that, we recognize and we think that mifepristone will be safe in labor. And we know that mifepristone really acts on the cervix rather than the uterus to prepare the cervix for labor induction. So we're anticipating that it's safe, and the next steps would kind of help guide us on a larger study, and hopefully including mifepristone as an outpatient use for labor induction. We know that if the uterus isn't stimulated, then there will be less of a chance of non-reassuring fetal heart tracings. So I think, it's challenging to randomize patients to an outpatient study with a new medication, but I think long-term goals, that would be the goal, is have patients go home. The mechanism of action really is that the mifepristone works after 24 hours, ideally. So the patient would go home, take mifepristone, come back to labor and delivery unit, and would have a more expedited labor induction.
Great. Thank you. Well, thank you, everybody. We will go to break now. We'll come back at 3:45. Great. Thank you.
Great. Thanks all.
Thank you so much, Dr. Lyell, and thank you so much, everyone, for spending time here on your Friday afternoon. It's a true pleasure to be speaking with you today, and it was wonderful to hear some of the presentations so far. It's great to hear that many of you are engaging in some level of partnerships with the community and some community engaged work. So hopefully you can learn a little bit more and see how that applies to this presentation. I'll be talking a bit more about principles of community engagement and some best practices. We'll talk a little bit about a definition of community engagement and what it is for those of you who might be less familiar with it, but we'll spend most of our time thinking about how can we apply frameworks for community engagement, in particularly community-based participatory research, to guide the research as well as to guide evaluations, and talk a bit about what do we mean when we talk about equitable partnerships and what are some of the best practices involved in that work. So maybe we can start a bit at the beginning, thinking about what is community engagement, who are we talking about engaging, and why? So we really mean the process of working in collaboration with a variety of groups or interested parties that have some relevance to an outcome or an issue that we are trying to address. And for the purposes of this presentation, we're talking, or I'm talking about how do we work with one another in research. Several of you talked a little bit about this piece of when we think about stakeholders or interested groups, who are we really talking about? Today, you'll hear me say things like partner or community partner, but that can mean a variety of groups depending on your work and depending on the issue that you are addressing. Here are just a few examples of them. They could be patients or caregivers who are impacted by the issue. Many of you might be working with birthing individuals with their significant others or caregivers. This can also be providers, staff. Dr. Main, for example, talk about engaging with nurses. I do a lot of work with community-based organizations, especially at the local level, who are providing services in a particular space, or our advocacy groups. Many of you might be working with healthcare systems, public health departments as well. And many of us like to engage as well with decision makers, thinking about how can we engage with those who have the powers to actually move the needle and implement many of the things that we are recommending. So engaging with policymakers and others. So this is really engaging with the groups that are most relevant to your work. Here's a more detailed definition of community engagement. We're thinking in particularly about the collaboration between institutions of higher education, including Stanford, and our larger community outside of our walls. And how do we do that in something that is mutually beneficial and that is in the context of an equal partnership and that there's equal benefit and reciprocity. I also wanted to highlight that community engagement can happen in many spaces. I do a lot of work in community engagement that is research related. Many of you spend a lot of your time in research, which is at the bottom right here, but there are many other ways in which we can think about community engagement. Education is one of them, clinical care, something that our institution also does a lot of. And oftentimes when people hear the term community engagement, they might also be thinking about things like community outreach, community education, volunteering, and service. And there's, of course, policy and advocacy work that we might be engaging in as well. So there's a variety of places, of activities and domains for this work. I'll be concentrating in particular on the research aspect. Community engagement also can be thought about as happening in a spectrum, anywhere from community outreach, which I will note is something that some experts in the field do not consider community engagement. But as we move from outreach to share leadership, this is a spectrum that changes in intensity, and as we move from the left to the right, we see increasing levels of communication, of trust, of shared decision-making, shared resources, and shared leadership. I like to think of this as we can go from work or research that is happening in the community or is based in the community to work that happens with the community and ideally by the community, as we think of work that involves more collaboration and more shared leadership. I'll spend a little bit of time today talking about community-based participatory research in particular, which lies a bit more on the right towards the shared leadership spectrum of this continuum. But this is something that is dynamic as well. A particular project or your work can be in different of the stages at different points. We know some work, for example, that might be more formative at the beginning, that it might be a bit more of consultation, for example, of outreach or understanding an issue or understanding community voices and their expressed need for solutions. But that work can then move along this spectrum and eventually be some work that might be work that is considered more equitable or that involves more shared leadership. So I encourage you to think about where some of your projects or your overall research lies and what are some steps that you can take from this presentation or from other work of your own to move that, even if it's just to move one step to the right in this continuum. I mentioned that I'll be speaking primarily about community-based participatory research, which is one of the most well-known and that has some of the most well-known literature within community engagement. There are many definitions of CBPR or community-based participatory research. This is one that I oftentimes use in that this is a collaborative approach to research. And I want to highlight this word approach, which is really important. This is not a method or a set of methods, but instead an orientation to research. So many of you might be trained quantitatively. Some of you might do mixed methods work. You can still do whatever methods make sense to address your research question. You're just doing it with this focus or with this approach of equitable partnerships. This is work that equitably involves all partners. We'll speak in a second about what that means, but it's really involving your partners in all stages of the research. Work that starts with a topic of importance to the community. So this is something that is driven by the partners, not just driven by the academic interests or the funders. And that is really, there's an explicit aim of combining knowledge and action for social change to improve community health and eliminate disparities. So there's an explicit value of social justice oftentimes in this work. We think community engagement and CBPR can collectively overcome some of the challenges that we know plague some of our traditional methods or collaboration, including oftentimes issues of mistrust, in that some of the work that has been done in academia has created some real harm for communities, and that oftentimes our academic medical centers are not seen as addressing the needs, especially of some of our local communities. We also know oftentimes our work lacks in sustainability. We go from study to study in terms of funding, but oftentimes we have some more difficulties translating our works into real programmatic or policy changes. And hearing some of the presentations here today, many of the issues that we are trying to address, especially many of you working on addressing equities, we know these are things that are incredibly complicated and that will take likely multi-sectoral efforts and collaborations to address. I want to highlight briefly some principles of community engagement out of CBPR. There's a strong literature highlighting many principles. Here, just a few of them and some that many textbooks and many books have in common. one, thinking that we are coming in this work with a slightly different perspective, one in which we are really trying to hear from everyone's views and trying to learn from one another. So we're really engaging in some communication that is bidirectional and really trying to engage in some knowledge co-creation that is really bidirectional, where all voices are valued and thought out. As I was mentioning, that many of the issues that we work is, especially issues related to systemic racism or trying to address inequities in birth or severe maternal morbidity or mortality, would likely require long-term efforts. So oftentimes these partnerships are long-term partnerships where the groups engage in multiple projects and multiple efforts. The specific individuals involved might change over time, but the group shares this long-term commitment to the issue. Another one is that one of the best practices is really thinking about power sharing. So community engagement, really creating an atmosphere of democratic participation and democratic decision-making, where the partners, the variety of partners feel like they have a voice in the final decisions and as well in the use of the resources for the partnership. This is also a strength-based approach with the various groups and organizations really engage in principles of empowerment, and we really meet people where they are in the partnership. And lastly here, I highlight capacity building or development. This is what I have spent most of my research and time in, but really thinking about capacity building both for academics and for other partners with the rationale that for engagement efforts to be truly equitable, effective, and sustainable, all groups involved must be really ready to collaborate and to really showcase some leadership. So really engaging in capacity building before we might even start a project. I also wanted to know that perhaps many of you know that there's an increasing interest by funders, by national organizations and others in having more community engagement. But perhaps something that some of you might not know is that our knowledge and our science of community engagement, and especially of CVPR, has really increased over the last decade. This is an empirical model led by Dr. Nina Wallerstein, who's actually on campus next week, if you can see her talk, Bonnie Duran and others. This is national global efforts. This was actually, I'm lucky to have been part of this team before I came to Stanford, but this is an empirical model of CVPR based on over 450 partnerships nationwide. This is successful partnerships, meaning they had NIH funding and they had engaged in multiple projects together. So we did a lot of survey data collection, a lot of in-depth qualitative work and case studies to really learn what does it mean to engage in authentic partnership efforts and what are some of the best practices that the successful partnerships share. And we also have measures that we have developed that go along with a variety of the constructs highlighted here. This is a model, and I'm happy to share more resources outside of this talk, but a model that groups can use at the start of their project, out of their partnership to plan ahead, as well as existing partnerships can use it to evaluate and improve their current efforts. And this is a model that is dynamic as well, and that can promote some reflection in the practices that we're engaging in as partners. I'll highlight briefly some of the different components. We oftentimes encourage groups to think first about what are the outcomes that they are trying to address, what is the issue, what are some things that they like to address both in the short term and in the long term. And from there to backtrack and to thinking about that issue that you are trying to address, what is the context behind it? Meaning, what are the social, cultural, economic, political, and other factors that really ground this partnership, both in the local, state, or national issues? So really thinking in a way about what are the socio-ecological influence, both on the issue that you're trying to address, as well as on your partnership. These are some of the pieces that you see at the top and in the middle. But it also really involves thinking about capacity and about readiness, again, for the academic team and for the other ones. Do you really have the capacity to engage together? And are you ready to do this at this moment? It also involves contending with oftentimes issues of trust and mistrust in our academic institutions. So contending with those and creating some trust and some building there before potentially engaging in the work. The model also involves thinking a bit about, once we have decided to engage in a project together or we have a partnership, really thinking thoughtfully about who is in the table and how are we presenting and engaging with one another. This involves thinking about the individuals involved and their characteristics. What are their skills that each of us bring to the table, our attitudes, our reputation, both for the academics and for other partners. And we've done a lot of work in developing both measures and constructs around what are those relationship practices that predict better outcomes. So for example, how are we creating a culture of trust? How are we creating space to engage in collective reflection, in discussion, in dialogue? Are we listening to one another, or do we have a system that it feels more hierarchical, as well as how does a partnership assesses or feels about the resource management? And do we have a system in place for democratic decision-making? In the case of a conflict, for example, do we have systems in place to address that? We also know that it matters to think about what are some of our structures. So for example, do we have power equalizing structures within our partnerships? For example, do we have formal agreements? How do we control the resources, and how much does the partnership adheres to CVPR principles? And moving us one domain over in the model is really thinking about this partnerships processes and practices also shape the nature and the extent of the partners to be able to equally contribute to the research. The idea that these partnership practices should have enhanced our ability to come up with research, with evaluation, or with designs that are actually reflective of the context and the needs of the communities and the partners that we're working with, and that really are centered on cultural issues. Notice that here it says cultural center interventions. It doesn't say adapted or tailored, but that because of this process, we have been able to create a product that is really different. I also like to highlight here on the asterisk that one of the best practices is when our partners are involved in all aspects of the research, anywhere from the design to the data analysis to dissemination and interpretation. And I'd like to end with helping us think a bit about some of the best practices that have come from this model and from this work. This is some of the work that I have done, as well as some of my colleagues, really utilizing this data to test this empirical framework and helping us think about a theory of change. And I'll leave you with some of there are many best practices that have come out of this work, but I'll highlight a few here for each of the domains that I just went over. When we think about the context that sets up a successful partnership, thinking about capacity development is one of the best practices, both at the beginning and throughout the project, really investing significantly on that to make sure that all partners have what they need to work effectively. And this is one of the practices that leads to more sustainability of partnerships, both thinking about skills, but also connections. And I highlight that connections with decision makers is one of those. I mentioned briefly before that when we think about what is the structure of our partnership, really working on formal agreements and formal structures that can equalize power. When we think about what makes an equitable partnership, this is part of those best practices. And one practical one is that partnerships that have formal agreements, whether it's in the form of memorandums of agreement or understanding partnership agreements, those partnerships tend to have better outcomes. Another practical one is thinking about how much money goes to the community, and that is one of the best practices of thinking about the percent of funds that goes to the community. I was pleased to see a recent application, a recent grant that I submitted to NIH. A requirement was that 35% of our budget went to the community. I think we did better. I think for ours, about 50% of our budget was for the community. And stewardship here is like one of the things that we find in this work is that if the partners involved perceiving that the PI in particular is being a good steward of the funds. And I had like maybe the last one here, the community involvement is that one of the best practices is trying to really think, and the partnerships that have community members involved in a variety of stages, whether it's the design of the intervention, for example, data collection as well as analysis, and data collection is one of the strongest predictors here. And this is, I think, my last slide, but I also wanted to highlight that this work is sometimes very difficult. Sometimes there's a lot of institutional barriers that make this work a bit difficult. And this is something that is not just unique for Stanford, but unique to many academic and medical centers. We have a PCORI-funded engagement award. We have a champion team here at Stanford that includes members of a variety of the community engagement offices, including some Anisha Patel, for example, here with the Maternal and Child Health Community Engagement Office. And we have engaged in a variety of assessments to see the culture here at Stanford, what are some of the challenges and facilitators of this work. And out of this, our champion team is leading two initiatives. One, to revamp some of our IRB processes to ensure that community engaged applications are reviewed in a different way, as well as streamline our post-award policies to ensure that we can streamline the process of contracts and payments to community partners. So you might be hearing from us, and some of you may have participated in some of this work. So I wanted to highlight that and highlight a few members of our team, especially our Office of Community Engagement here. And with that, I think this is all of my time. Thank you.
Great. Thank you so much for that wonderful presentation. Reminder, we're going to do all questions at the end. So please, if anyone has questions, please put them in the chat and we'll get to those after the next two speed talks. So it is a pleasure now to introduce Kata Nemeth. Kata holds a master's in public health administration and is the project manager at Black Wellness and Prosperity Center, where she's critical to moving community projects and partnerships forward. Prior to this, Kata was a Fulbright scholar and served at the European Free Trade Association, where she worked on several multi-year projects across EU countries. She's experienced in managing human rights and maternal health projects. And during her tenure with the European Roma Institute for Arts and Culture, Kata managed the implementation of complex programs. She's also served as a fellow in Washington, D.C., where she managed human rights and foreign policy portfolios. She's been a wonderful partner in our anemia work, and it is a pleasure to hear her perspectives.
Thank you so much, Dr. Lyell. Thank you so much for this excellent keynote presentation. I'm hoping I'm not going to repeat a lot of things, but rather add some useful information. And thank you so much for having me. It's really, really great that we can share about some of our work while we are working with the community. And as you know my name by now, I am Kata Nemeth, and I work with the Black Wellness and Prosperity Center. Just a very little insert about the Black Wellness and Prosperity Center. We are based in Fresno, and we are a CBO, and we focus on the unmet needs of Black mothers and babies, because that's where the biggest disparity is in Fresno County. And we want to serve the Black community and improve their well-being and prosperity. And I would like to talk about the work that we did together in partnership with Dr. Lyell and the team. And thank you so much for several times referring to our work. And without this, without any further introduction, I'm going to share a video and the presentation because that keeps me on focus. So let me just share my screen, and please let me know if you don't hear it or if there is something wrong with the video.
Oh, Katya, you're muted.
Okay, thank you so much for watching this video with us. And sorry about the gray boxes, it was the chat panel. And I would like to highlight just a couple of works in my remaining 1 minute. As you saw that it was a qualitative work, and mostly it is really listening sessions and community conversations. That's what we want to focus on. The way how we approach our qualitative interviews is always about conversations. And the aim was really establishing the ACLG group, and we used monthly conversations via Zoom, and these were very deep 2-hour-long conversations with the center on centering the conversation nature of these meetings, of these consultation meetings, and amplifying the experiences of community voices. That's why you saw that we added the names, because several of them experienced that it's very important for them for their names to be added. And it was one of the most unique aspects of this work was really that they were able, whether institutional members or community voices, they were able to engage with each other in a very authentic and very honest and safe way. And they were making sure that it's a non-hierarchical space. We were also making sure that, but the key part was that participants were also making sure that. The aim too was collecting experiences from birthing persons, individuals who experienced anemia during pregnancy, and they live in California. These were, again, not traditionally qualitative interviews in the traditional sense. They were, again, conversations, especially when we had not individual conversations with the birthing person or culturally concordant conversations in small groups with 2 or 3 people. And just a couple of things we learned, 4 things I want to highlight. Participants were really eager to engage with each other and share experiences and learn from the experiences in the same, in a safe space. And while there were lots of resonating experiences, especially when it comes to what are the lenses of a BIPOC person, we also understood that no 2 pregnancy experiences are the same experiences. And it was really important learning for us. The other thing I want to highlight that participants kept voicing that there are lots of other important aspects. Anemia is certainly one thing that requires more attention when it comes to pregnancy care, but there are lots of other ways that make pregnancy care continuum whole: mental health, wellness, and the holistic care of a person. So I think there are lots of things I want to add, but I also just want to highlight that we are also working on a very short brief that will be shortly shared about our work, and that will be also outlining the next steps that we want to work on, whether it's anemia related or pregnancy care related, and community education materials. So thank you so much for the time and the attention. I hope I didn't go too much over my time, and I stop here.
Thank you. No, that was perfect, and we'll circle back with questions later. But we have our third and final speed talk. We're going to hear from Dr. Julia Simard on mixed methods approaches to inform decision-making in clinical care. Dr. Simard is an associate professor of epidemiology and population health at Stanford, and by courtesy of medicine and obstetrics and gynecology. She's an epidemiologist, and much of her research addresses pregnancy outcomes among people with lupus and other autoimmune disorders, especially related to prevention of preeclampsia and preterm delivery. She's also leading research to understand the role of gender and race-based implicit bias in medical diagnoses. So welcome, Dr. Simard.
Thank you so much. I will share. Are you seeing the correct presentation?
Yes.
Great. Okay, so since it's a speed talk, I will try to be speedy. Thank you for the introduction and for the opportunity to share a quick overview of some of the work in progress that we have going on, where we're employing mixed methods to try to inform decision-making in clinical care in the context of the conditions that Dr. Lyell mentioned. So we started, one of my grants is focused on looking at whether hydroxychloroquine, and I'll say this grant was written and funded pre-COVID, but whether there were alternative uses for hydroxychloroquine potentially in reducing the risk of preeclampsia and therefore preterm birth. And we were really interested in trying to better understand hydroxychloroquine use. Several years ago, several colleagues and I conducted a study using Swedish register data, and we showed that this top blue line here represents hydroxychloroquine dispensings from the pharmacies. And we found that no more than about a third of pregnant lupus patients filled a prescription for hydroxychloroquine. When we looked at roughly 11 studies published in about the past decade or so that happened to have data on hydroxychloroquine use in lupus pregnancy, fewer than half of SLE patients were using hydroxychloroquine in pregnancy in most of the studies. The two bars just denote the two studies that I contributed to that literature, and then the rest were other studies. The data from these 11 studies were based on a variety of different sources, including self-report, medical record abstraction, claims, dispensing data. But why does this even matter? Well, it turns out that the recommendations and guidelines by the American College of Rheumatology is to use hydroxychloroquine in pregnancy for lupus pregnancy. And so this all seems very low. But one of the things that we noticed in talking to clinicians is that this is also often interpreted as low patient adherence. And so working with Kaiser Permanente Northern California in collaboration both with patient and physician partners, we collected more quantitative data to try to understand what might be going on. Are these patients not filling their prescriptions, or is it possible that the prescriptions aren't even being written? When we compared you can see here we have orders, fills, and then fills within 30 days. And this was during the entire study period and then 2 other study periods. And then we didn't look at 2020 separately because it was a funny year for hydroxychloroquine. So when we compared the prescription orders to fills to look at primary adherence, we found that fill rates were actually quite high. So when there was a new order written, it was filled over 93% of the time in pregnancy. And this is in lupus pregnancy specifically. And in fact, over 83% of them were filled within 30 days. When we expand beyond new orders, we looked at ongoing prescriptions that had sort of the opportunity to be refilled during the pregnancy. And we found that between 53 and 69% of lupus pregnancies even had the opportunity to fill a prescription for hydroxychloroquine. meaning that over 30% didn't even have a prescription on file to be filled. And so that points to some questions about when we interpret data on dispensings as patients being non-adherent, actually 30% or more of the patients don't even have the opportunity to fill it because the order's not there. So we are taking these quantitative findings from our studies, and we're planning a series of qualitative studies using focus groups with patients and providers, which we will be doing separately, to identify the barriers and facilitators to using hydroxychloroquine during pregnancy, as well as for prescribing it and kind of the clinical guideline adherence. Without this piece of information, we're not really going to be able to identify effective strategies to improve adherence to clinical guidelines, nor adherence to medication use by patients. Now, I'll really quickly go through the second example, which is that there is this clinical conundrum in managing lupus pregnancy, which is that there's a series of manifestations and risk factors that present very similarly in a lupus pregnancy and make it very difficult to distinguish between whether a patient is having a flare of lupus nephritis or actually has preeclampsia. And without biopsy, which we found looking in a number of data sources is actually pretty rare during this time, we don't have even a gold standard. So we're doing a case series that we're wrapping up now, where we're looking very closely in a group of lupus preeclampsia patients that were diagnosed at Stanford to get a sense of kind of what are the parameters that physicians are using to say that it's preeclampsia. And really to inform this more, we're doing a second quantitative study where we're using randomized surveys. Thinking about studies from disciplines like economics and sociology, where identical resumes are sent out with names and identities modified to study discrimination in hiring practices, we decided to leverage this approach with a focus on clinical diagnoses. Collaborating with colleagues in OBGYN, rheumatology, and nephrology, we have developed a series of case vignettes where different patient characteristics or clinical parameters are going to be randomly modified to determine how those factors might influence the clinical decision-making, including asking about next therapeutic or diagnostic steps and differential diagnoses. And then these results, in combination with the case series work, will inform our qualitative step, making this kind of a mixed method project overall. So taking these quantitative findings from the case series and the randomized surveys, we will be conducting a series of qualitative studies, likely using a combination of focus groups and structured interviews, where we will be presenting our quantitative results to clinicians across these same three disciplines, rheumatology, nephrology, and OBGYN, to discuss the results and get the specialists' input on how to interpret and contextualize these findings. I know this was a whirlwind and time is up, so I just really quickly want to list my collaborators for all the various projects and a number of the funding sources that have supported some of this work. Thank you so much.
Great, thank you. Well, you guys all kept us pretty much on time, so thank you. That was great. Reminder for adding questions to chat. I have several and would love to just hear everybody's input on these. For Dr. Rodriguez Espinosa, one question, you lead a lot of work at Stanford and we have a lot of trainees and different people who are maybe newer to these methods. Can you name, and you did a little bit in your talk, but also just to highlight, underscore resources that those who are doing this kind of work and want to learn more and do it correctly, where can we get more information?
Absolutely. Excellent question. I usually have a slide, but I think I omitted it for this talk. I think our own office, I'll put the link in the chat in a second. We have a research page that has both reading materials, but it also has different places where individuals can go for some short videos, some self-paced materials. So I would say looking at a resource guide will be one place. We have some courses, so both myself and Dr. Lisa Goldman-Rosas teach some formal classes, both in community engagement, and we're developing a course next year in CVPR in particular that will be more advanced. And another resource that I highlight is a variety of the seed grants that are happening on our School of Medicine. There were several due today, I believe, for my own office offers some seed grants, and particularly for the stage of partnership development, where you might be interested in having some more funds to the development of the partnership, some pilot data collection, for example, that can set the stage for future grants. That should open up in, I believe, the spring. Yeah, so I highly encourage you, if you're thinking about a new partnership, to apply for that.
Thank you. And I have one more question, and then I'll free you up to type these in the chat, because I know others are interested too. In your experience in these community partnership work, where's the biggest threat for something to break down? And that may be a very broad question that may be impossible to answer, but I'm wondering if you can comment on what people should really consider for where this can sort of go awry.
Mm-hmm. Sure, it's a large question. Maybe I'll tie it to some of the work that we're doing. We're part of several national groups, and I mentioned we're trying to do some work here at Stanford, but there's oftentimes a lot of administrative challenges that even groups that are committed to the work, that are ready for partnering. We know some groups, even here at Stanford, that have received funding, but they cannot move to the next stage because of the huge barriers, oftentimes barriers related to the IRB, but also administrative barriers when it comes, for example, to paying partners. It can be a very difficult process, and one that, especially if you're partnering with groups that are not able to fund the work at the beginning and wait oftentimes months and months for contracts to be in place, that can be a major challenge, especially for partnering with small community-based organizations. When we think about our post-award processes, we treat them the same no matter the size of our partner. So if we're partnering with somewhere like UCSF, they go through the exact same process that some of my partners have to go through, who are a very small co-op that might not have English speakers, for example, on staff, that might not have the same level of resources. So I would say not underestimating the amount of administrative resources that go into the back end of supporting the partnerships and supporting the research.
Yeah, no, I'm glad you brought that up. We ran into that, and it was not easy the internal kind of hurdles at Stanford. I'm wondering,
and you have to manage then the relationship based on those hurdles that are happening, and why the work is not moving forward, and why you're not able to pay, or why partners have to wait so long, even after we wait already so long for grants to go in and to get reviewed. So it creates a bit of a strain in the partnership.
Right. No, thank you. And Katja, I want to turn to you. You led such great kind of community-based work. What are the greatest barriers, or what, from your perspective, particularly within Black wellness and prosperity, and running the recent Anemia community leadership group that you did, from your perspective, where are the barriers?
What are the very barriers for partnering with institutions or partnering with the community?
Partnering with both, either the institution or with the community. What are some things that we should be aware of, just those of us who are perhaps interested in doing this kind of work?
But I think, just to answer it from my own perspective, partnering with the community, it's not going to be really fast. And it's not always a linear progress. There are lots of steps. It's I think it's not going to go well if we only have a short period of time, because trust is not going to be built from one day to another. It needs lots of investment, and in terms of time, and making sure that they know who you are, you are you are invested in them, because it's not just one-way direction. It's transactional. The whole situation and the whole partnership is transactional. So I think that's one thing. And working with the community, what we believe in, and in this work we also centered it very well. We need to make sure, and we prioritize that. You saw one of the quotes when one of the participants mentioned that I'm not necessarily doing it for cash rewards or anything like that. However, it is a necessary requirement, not from the participants just because of equity and just because who we are. It's necessary for participants to be compensated, and for their input, for their time, for their experiences in a way that we want them to compensate. So sometimes that can be an issue to find a means. And just, yes, so I think I just want to say that time to build trust and understand that these are heavy topics to talk about. It's not always, people are really, really open for sharing once they feel safe, but there are certain topics, especially when it comes to discussing reproductive health and talking about your own body as a female, as a woman, as a birthing person. You are told so many things what not to say about your body. So these are hard conversations that we are navigating. So I think if we are wanting to community engagement, we need to somehow work on these barriers and taboos.
Mm-hmm. Yeah, no, thank you. And thank you for all of the work you've done here. Julie, I wanted to ask you, I love this concept of quantitative, the mixed methods, but kind of going backwards, like quantitative to qualitative. And I'm wondering, just to really inform work, and it seems kind of like you could do that for a lot of different types of research, but is there any, in your work?
Even if we're talking about diagnoses, then presenting it to physicians and being like, what do you think's going on here is probably also valuable. So I'm still relatively new to it, but I would almost say anytime we're making an assumption, doing this type of work provides us an opportunity to dig more into whether our assumptions are right or not.
Great, thank you. And thank you to all of our speakers earlier in this session. This has been a wonderful session. We're gonna move now to the breakout sessions. So
all right. So please hang in there with us to do the breakouts, because this is an opportunity to really have smaller group discussion. It's good to try to do it the best we can in a Zoom venue, but we think these small groups will really help us process all of the breadth of things that we've talked about. So that's kind of the purpose of the breakouts. And also just, again, back to our part of our original or introductory comments, it's community building, we think, and a good way for people to get acquainted. So structurally, I'll tell you, Giannina is going to, we have a leader for each group, and then the rest of you are going to be like randomly assigned. There'll just be a handful of people per group. And we're going to have 15 minutes for the breakout. And then we'll have 15 minutes of, whole group discussion about what was kind of summarizing what was done in those breakouts. And then we'll have a brief wrap up from Deirdre and me, and then moving on to that happy hour. So I am going to put the prompts in the chat, but all of your group leaders will also have the prompts. So let me just do that real quick. And, this is meant to be, we have prompts to help provide some guidance, but also, yep, there they are. Also, feel free to talk about whatever you want to talk about. These are informal and really just to stimulate discussion. Anything else I'm leaving out there? Nope. Sound good?
Sounds great. And then we'll reconvene at 5:05.
All right. And now Giannina will do her.
The final. Right, guys. We'll reconvene before that because people are going to present back.
Right. We'll reconvene after the breakouts and then do breakout discussion together, and then
until 5:05.
Yeah. So Giannina can do her magic and put us into groups. Looks like we're already gone. Oh, we are in a group now, I think.
Yep. No, this is the main room still. I'm not sure that you wanted to go to a room.
Oh, okay.
Do you want to go to a room or do you want a break?
Well, Elliott and Marina should be taken care of, sent to groups first, because they're in this.
Yeah, the rooms got really small, so I just coordinated 3 rooms instead of 5 because it got really tiny.
Oh no, how
many people? There's
only 6 per room.
Oh, that's plenty. I don't really want it to be any bigger than 6.
Okay.
So, okay. So the leaders will deal with it.
Yeah, they have enough leaders. They have a leader in each room. It's just that when I had 5 rooms, there was a room with 3, and then it was like really small. So then I just made it into 3 rooms.
Okay. Yeah. And what time are we? So how long? When will
I set a timer, so you can see in the upper corner the 15 minutes. So 13 minutes from now, around 55.
55. Okay.
Yeah. Do you see the timer? Oh, you'll have a time. People will see a timer if they're in a group.
Okay, but if it's at 55, that's great. And then,
Okay.
So they'll have 55, and then if it's only 3 groups, then that actually makes it easier in terms of fewer presentations. It won't take as long.
Okay.
Because I worry about things running over then. Okay, I'm gonna run upstairs, and I think Jackie's here, and Sarah, and just see if they need help.
Okay.
I'm gonna just write. Also, can I just put the address?
Oh, yes, in the chat.
Yeah. How can I?
Just go down there. I'll do it. Oops, did they not go?
I don't think it's sent. Oh, there.
didn't send.
That's why. Shoot.
Janina?
Okay, I can put it.
Will people be able to see when they're in a breakout? Are they able to see the
No. Do you want to send me the address and I'll just share it out again later when you close?
If you can put something just says join us for happy hour.
Yeah, I'll share it at the end when you start to do your closing remarks.
Oh, right. That'll go through though, right? I guess my prompts didn't go through because I didn't hit enter.
Yeah, but they all have the slide deck.
Oh, I see.
All right. Cool. Thank you.
Okay, I'm sending you that. Okay, I'm gonna go upstairs.
We're good. And so our 5 till 5, 4:55.
Yeah. I'm gonna.
Can you?
Yes.
Can you actually tell who is like in the groups? Or
yeah, I can.
Stayed in. So did people stay in?
Yeah, the 6 in each group did stay.
Okay. Cool. Thanks.
Yeah.
Shoot. I'm gonna have to go. I'll be right back.
All right. I'll give. There we go. Great. Janina, does that look like everybody's back?
Yes, that's everybody.
Excellent. All right. Well, Deirdre will be back in a minute. But hopefully that worked technically for everyone. And I think now what we wanted to do was just kind of have someone from each group report, kind of give a summary of what you guys talked about. And I look forward to hearing what that was. So anybody want to jump in?
I can jump in before I forget.
Go first, Ira.
Was there someone else who? Yeah. Okay. So I'm Ira Ikpenosa, a newly minted MFM instructor, faculty, Warher. And so in our group we had a good mix. Where do we have the greatest promise currently for productive, impactive health research? And in general, the consensus was this was a good time to to use the momentum and the attention for maternal health research. And everybody's kind of noticed this either from their department of epidemiology or OB-GYN or other medicine spaces that this is like focused attention that wasn't there maybe 10 years ago. And so that we can really gain from that momentum. And this is also where Stanford could potentially lead, especially in our models of engaging and learning and community engagement. And so we shared how there's really not a great blueprint for how to do community engagement well. And maybe as we have our learning lessons and we potentially have longer partnerships, we can kind of share models for best practice. And then some of the challenges we mentioned is that, Stanford is big and there's so many resources, but maybe identifying what would be like this conference was like a great opportunity for us to get to know each other, for those who are interested in similar research topics, and kind of more things like that that kind of can kind of like just identify resources and potential collaborators and kind of point you to that, where it just kind of takes away some of the noise. So that's our summary.
Thank you. Appreciate that. Someone from one of the other breakouts?
I'll try not to be shy, okay? So we worked on a number of areas, and our focus was, are there areas that are important in maternal fetal health research at where we have gaps, and either gaps nationally or gaps that we're missing here at Stanford. And we came up with a list of about 6 of these. And Janine started off by identifying maternal care deserts. And there are a lot of counties that are pretty rural and don't have access to expert care. And particularly in an era where we have developed telemedicine, this could be a very, very important combination of outreach in person as well as electronically. Second, a couple of us, Cod in particular, identified the area of syphilis. We have a national epidemic of congenital syphilis. This should be remediable in a country with our resources and wealth. There should never be a case of congenital syphilis, and yet we have record numbers of cases. Let's append to that the problem of HIV. HIV was not mentioned in the 3 hours of our conference today, and we have the kind of convergence of opioids and HIV, and that might be an opportunity as well. Third, we have heard about great work going on in postpartum care and the epidemiology of problems of postpartum care. This is sometimes now called the 4th trimester. Yet we know that a considerable percentage of women never go to their postpartum care visit. And I think led by Susan, we're beginning to recognize that the allegiance to the 6-week postpartum care visit is just wrong. The timing of the postpartum care visit might be better if it were done earlier. And it need not be essentially in person. It could be done by Zoom, by phone, and home visits to really make the postpartum care visit one that catches problems earlier. And then we also identified certain incentive structures, certain employers providing incentives for persons to get to their postpartum visit. We came up with mental health. We identified that mental health is a major reason for readmission in the postpartum period, and that pediatricians are screening mothers for mental health during the newborn exam. Well, this is another reason that we might want to even engage in a trial as to earlier postpartum visits. Inequities are also on our list, and ways of taking those down through community engagement in particular. And finally, I dared to mention the word abortion. And the reason in particular is that obviously the landscape is changing nationally. And if you look at maternal morbidity, a considerable part comes from women who have abortion. And if we have an outbreak of illegal abortions or people coming to California for more numbers of abortions, I think we should give some thought as to whether this should be part of our research portfolio. I'm exhausted, but we had a great time.
Thank you.
I love it. I just joined a PCORNet committee that is tasked with giving them developing recommendations for research, a research agenda, as well as, what are the research gaps, as well as what are the needs to address it as far as data, et cetera. So I'm going to keep that list.
Okay, did you get it all down, Susan?
I think so.
Okay.
I think
I took notes.
Yeah, thanks.
I took notes.
And we're writing all of your.
Maybe I'll just finish with some of the things that our group was discussing. We focused on the opportunities. And a lot of people just really loved this session. And we talked about all the diversity that we saw today and in terms of projects and the data that we have, and that there is truly a lot of opportunity in collaboration within this group. We talked about bringing people together a little bit more under this umbrella and finding more forums to get together, and whether that's just networking or whether that's grants that people can do together. Talked about RFAs for pilot studies where multidisciplinary plan is encouraged, so perhaps starting with those. And then we also talked about the importance of community engagement, that it really starts with interest from us, from the organization, and building the trust with the community. Yeah, we finished with kind of the final thoughts were that there is really a lot of power in the multidisciplinary work and power in mixed methods. So let's collate all those pieces and be powerful together.
Great. Any other comments to add to those? Please feel free to speak up, share anything, from, on these themes to what you thought of this event or what you'd like to see more of. Just, there's only 18 of us, so I think we can do this now versus when there are 50. But we can also, we have a few more minutes, I think.
I was definitely saying that this is a wonderful opportunity to get all these different people perspectives coming from different places. And one of the things that in our group we talk about is need to foster research and in a collaborative effort. So see grants thinking to have more than one PI. So because everybody thinks from different ways and different, it might be the same question, but approach it might be different. So have the ability to have PI from different specialists looking at the question, I think is interesting to put in the question. And other things that we're talking about is just how we can work in an efficient way to show the community that we're trustworthy and we can really be there and be an advocate and an asset to the community, since there's this element of mistrust with big institutions.
Deirdre, Susan, do you envision a target of something like a program project coming out of this?
Good question. I don't know. I mean, everybody probably doesn't know that we are working on it's sort of like a program project grant. Our NIH recently put out a call with a request for proposals for maternal health centers of excellence. And that's the first time I'm aware of, that's the first time that's happened. And so it's a great opportunity. We are, we're responding. So we're putting together a proposal. So that, I don't know if that answered, that's one piece that's going on, Ron, which would be it would be a great impetus to the work that we've all heard about today. Plus, we could do this, a whole different round of speakers and topics, more, in the future. There's a lot going on here. And I think there is a lot of momentum here at Stanford based on people, things that have been being an eye towards building towards this, especially by the Department of OBGYN and the opportunity with the Dunlevie Center. And now, we're going to try for this center grant.
Yeah, I think that under the umbrella of maternal fetal health, we've got a lot of strengths, and that would be a nice way to keep it going. In fact, even going through the application process.
Exactly.
Value.
Yeah. Because, yes, of course, we really hope we get it. At the same time, it's a lot of you put a lot of concerted effort, and you wind up with proposals that, as we know, when we don't get it the first time, we persevere and we keep trying. So it's, it's a lot of effort towards designing these projects, some of which you heard about today.
Yeah. If I can help, I'm always happy to chime in.
Thank you. But it just also highlights, I appreciate just all the different, and people have talked about it, the different disciplines that we have represented just, in this call, and different types of expertise that everybody has. And I just really appreciate that. And that's when it's the most, I think it's the best science, and it's the most fun when we can all, figure out how to work together. And
it did give me the idea, and thank you all for hanging in there, because it's a long session. So really appreciate all of you staying on, but we have these monthly meetings Thursdays. I think that the fourth Thursday, or the third of the month. I have to look at third or the fourth, from 12 to 1. If anyone's interested, that's within this domain of the Dunlevie Center. And we've had speakers before, or just discussions about things. It's relatively new, but this model of having sort of one longer speaker who's still, 20 minutes is not that much, but boy, we learned so much today from our 3 keynote speakers in 20 minutes. And then the shorter ones, that may be a model that we consider in the future too, just in the coming year, until we do one of these again. But
the Beatles wrote about that style. They said, if you like my style, I can make it longer. Paperback writer.
Oh, but we're making it shorter. We're talking about shorter.
That's right. So
you
you make them shorter, and if you like my style, I can make it longer.
Gotcha. I like that.
Great. So
every fourth Thursday. Every fourth Thursday.
Thank you.
Thank you.
Thank you.
Any other comments before we wrap up?
I wanted to comment how much I appreciate the multidisciplinary approach here, and inviting people from so many different disciplines, but also just reiterating something that Ron brought up, with focusing on the full spectrum of maternal health, thinking about not just the part that we tend to focus on, which is the time that they're in the hospital, or being cared for by a team like ours, but also people have abortions, people have mental health issues in the after a pregnancy. So just thinking about the full spectrum, I think, is really important.
Yeah, great, good point. Good. Well, Susan, I wanted just to thank you all first for hanging in here, and a number of people who actually helped to plan this, all of our speakers for really taking the time to share your wisdom and knowledge. We know that summarizing this body of work and also staying with us is not, you're all busy people, and it was really very useful for everybody. And to those who helped to organize, Janina, who really kept us on target and on task here today, that was very helpful. And then Zara, Aziz, and Jackie, who helped to organize in many ways, and actually are both upstairs helping to set up the happy hour, which hopefully you guys can come to as kind of continuation of interacting and engaging with people from just different areas than your own. And Anna, definitely for your research and leadership expertise. You're always moving us forward within the Dunlevie program. Yasser, for your center leadership and wisdom. And then for our administrative departmental leadership, Leslie Subak and Usha Chiba and Sheila Dolezal. And then also to our breakout room leaders, thank you guys. And, we really appreciate it. I think we're all we all make each other stronger, basically, and better. So we hope you enjoyed the afternoon. We hope it's been a catalyst for ideas and more productive working relationships in the future, and really just appreciate your coming. Anything to add, or it's from both of us, but
I think that's a wrap.
I think it's a wrap. Thank you all.
Thank you.
And we hope